And if you believe with me, rise on your feet and let's sing together. Yo, 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 yo.
Good afternoon, good morning, everyone. Welcome to Africa Cafe 6. We are very excited for you to join our discussion around clinic community support and advanced HIV literacy, while we are prioritizing the children's rights and the health needs. So our cafe will be discussing and unpacking some of the interventions or managements or implementation of managing the children and adolescents with advanced HIV disease in a country context. How do they link with the community, and looking at the social support mechanism, as well as advocating the rights of the children and making sure that healthcare provider and the community really advocate to the rights of the children in the needs for health support, as well to improve their quality of life and well-being. So we'll have 3 sessions, which we'll start with Dr. Swilanji from Zambia, and then thereafter we'll go to Mr. Paul Okuruti and Mr. Saad Luyanda from Uweso, Uganda. Lastly, we'll go all the way to Nigeria from Ms. Bukola Ayinde, who will speak on the community interventions and advocating the rights of the children in managing the advanced HIV disease. So speaking of that, let me introduce our first presenter, Dr. Swilanji Suvile. He's a physician in internal medicine, but also with a Master's of Health System Innovation. He has 13 years in program design, implementation, and treatment of individuals with advanced HIV disease in Zambia. And currently he holds the, he is the focal point for managing advanced HIV disease in Zambia in the Ministry of Health. And his passion is improving the well-being of a patient with advanced HIV disease through medical education as well as clinical research. So Dr. Suvile will be speaking to the package of care for advanced HIV disease management. We'll share the experiences in Zambia, how they overcome the challenges and how they linked with the community to make sure that they provide a comprehensive package for children and adolescents with advanced HIV disease. Over to you, Dr. Swilanji Sivile. Thank you.
Good afternoon. Good morning, everyone. My name is Swilanji Sivile. I'm from Zambia. I'm the lead for treatment and care at the Ministry of Health. I'm going to take you through a presentation on patient-centered advanced HIV disease services in Zambia. This is just our experience with AHD here in Zambia at the Ministry of Health. So what is the problem? The problem is that there is no epidemic control, true epidemic control of HIV without reducing HIV-related deaths. In Zambia, of the 19,000 estimated HIV deaths every year, 5,000 are among children and young people. So HIV-related deaths still are a very big problem among children and young people. So advanced HIV disease is defined as a CD4 count below 200 cells per microliter, or a WHO stage of 3 and 4 events for adults. But for children, all children below the age of 5 years old are considered to have advanced HIV disease. And most of the deaths or among people living with HIV do occur within people who are affected with, who have advanced HIV disease. So this graph just shows that advanced HIV disease and deaths due to advanced HIV disease do occur among children who are much younger, below the age of 4. So the WHO has developed a package of care that must be systematically given to everybody who has advanced HIV disease. This care comprise of screening for opportunistic infections, prophylaxis, and rapid initiation of ART and counseling. So to deliver this care effectively to the populations, we must know that the causes of these deaths are severe bacterial infections, malnutrition, tuberculosis among children and young people. For adults, the leading causes of death include cryptococcal meningitis. So early diagnosis of HIV in younger children can prevent these deaths, because most of these deaths do occur in the very young people, young children below the age of 4. We did some analysis, and this is an abstract that was submitted to the IAS from our Zambia program, and we noted that most of the deaths do occur in very young children, and these have an undiagnosed HIV status. So these are missed children from our PMTCT cohorts. So we need to improve case finding, we need to improve adherence, and we need to ensure that viral suppression is improved for us to reduce these deaths. For those children who end up admitted with AIDS-related conditions, we need to enhance HIV or opportunistic infections diagnostics and also case management capabilities. So to do this, in Zambia, we have the hub and spoke model where we've put Pediatric Center of Excellences. These comprise of multidisciplinary teams that are able to provide excellent care for children who would have advanced HIV disease. They were mainly hubbed by infectious disease or experts or pediatricians, and they also have some linkages with community and referral support for our children. So we do also extend the services to the community. We know that 24% of all HIV discharges from the hospitals end up as community deaths in 3 months. This is from our data. And we do use community-based volunteers to follow up these children to enhance adherence and make sure they are taking their drugs for both prophylaxis, ART, and also the treatment of opportunistic infections that they may have. And we've also come up with a number of DSD, that's differentiated service delivery models for children. So our practice is that those children that are viremic or do have advanced HIV disease, we don't remove them from the DSD models, whether these are community ART distributions or groups. They still have to remain in those groups so that they can get support while they are very sick. And this has, in our view, given some very good outcomes. We've also taken up advocacy. So we work with CSOs, of which in their scope of work, especially those supported by both PEPFAR and the Global Fund, they should have advanced HIV disease materials during their work as they go in the community. We do encourage that the leadership and the lobbying and the advocacy for reducing HIV-related deaths must come from the community, especially the communities that represent people living with HIV themselves. Even though AHD is less, or HIV-related deaths are less among children, we still feel that every child who we lose is once too many. And as you know, all children have the right to life. So even though we know that for most of the work globally, like the Global Alliance to End AIDS, does not really bring out issues of advanced HIV disease in pillars, we feel this is an area that the global community can continue to look at and probably even increase funding and technical support directed specifically towards this particular population. So thank you for listening to me. I think in conclusion, in a nutshell, of what we wanted to share in Zambia is we still have HIV-related deaths among children, and there is some package of care that can reduce these deaths. We need to find innovative ways of making sure that these reach the populations, like we are doing using the hub and spoke models. We have these pediatric centric centers of excellence providing these services, but community support as well is very critical because of most of the deaths occur in the community. Yeah, so for those of you who want to get in touch with us, those are my contacts at the Ministry of Health, Zambia. Thank you very much.
Thank you, Dr. Suvile, for this opportunity to learn from Zambia what is what is happening there with managing the children and adolescents with advanced HIV disease. What I take from you is the enhancing the early infants diagnosis, improve case findings, enhance HIV opportunistic infection diagnosis, as well as keeping these children who have been diagnosed with advanced HIV disease continue with the differentiated care. So now moving to our second presentation, which will focus mainly on exploring the social mechanism in the care of emergency. I'm introducing Mr. Paul Okuruti from Uganda. He is a case management advisor at Uganda Women Effort to Save Orphan and Vulnerable Children. He has 11 years experiences in working in Sub-Saharan Africa in case managing these orphan and vulnerable children in the community as well as in the facilities. The program is supported by USAID. Welcome, Mr. Paul, over to you.
Thank you, and good afternoon, everyone. Here in Uganda, it's 1 o'clock. And so I'm very glad that I'll be taking through exploring the social support mechanisms for emergency care among children and adolescents living with HIV. Okay, and has already been introduced that I work for Uganda Women's Effort to Save Orphans, an organization that is implementing a USAID-funded activity that is called the USAID OVC Northeast activity for 5 years. Next. Yeah, so Uganda Women's Effort to Save Orphans is a national NGO operating in Uganda, and we are implementing a USAID-funded OVC program aimed at preventing new HIV infections and reduce vulnerability among the orphans and vulnerable children and adolescents and young girls in the northern part of the country. So this activity is implemented in 6 districts in the country, as well as 2 cities. And our main target population is the children and adolescents living with HIV, HIV-exposed infants, children of HIV-positive caregivers, survivors of violence against children, children of female sex workers, and then pregnant and teenage mothers. So our major areas of focus are case management, gender and social protection, economic strengthening and youth inclusion, and then child protection system strengthening. Next. So as an activity, we have 6 key strategies that we use to be able to support children and adolescents in with advanced HIV disease. And the first strategy that we use is we conduct a joint root cause analysis and action plan for adolescents living with HIV, those specifically who are non-suppressing. So why do we conduct a joint root cause analysis? We basically conduct it to understand the underlying factors for viral load non-suppression among the children and adolescents. For example, we will be able to ascertain that maybe the core root causes for non-suppression could be limited treatment literacy, food deficiencies, transport challenges, among others. And so in Uganda, what we normally do as we are conducting this root cause analysis, we work closely with the health facility team. The health facility team comes together with the communities team to be able to dive deeper into the records, the clinical records of these children, and then also be able to interact with their caregivers to try to understand better what could be the underlying factors for non-suppression among these children. And then thereafter, we jointly implement the action plan that has been developed together with the caregivers and the facility teams. And then thereafter, we proceed to now provide intensive adherence counseling and disclosure support. We also provide pre-appointment reminders because we have some of these beneficiaries who are getting into this situation because they are missing their clinic appointments. They are not going to pick their drugs because they are forgotten for many other reasons. So we provide pre-appointment reminders to them through text messages or calls. And then we also do a periodic tracking of children who have interrupted treatment, and then we follow them to ensure that they are supported to get back into care. So this has basically helped us to have clear response actions for our children. It has also helped us to reduce on the missed appointments and promote retention in care for our beneficiaries. And then it has also increased on the proportion of viral load suppression among the adolescents. Over a period of 1 year, we realized that we were able to move from 84% viral load suppression to 87%. And it has also improved retention among the children and adolescents. Like you can see the picture on the left, this is our facility team conducting a joint review. And then next, the second strategy is we have a tool that has been developed nationally by the Ministry of Health together with the partners that are supporting children, and that tool is called the audit tool, the pediatric audit tool. So the pediatric audit tool provides summaries of the client's information and aids the clinic and community staff to be able to quickly identify the issues affecting the treatment of these children, and then be able to develop an action plan to be able to follow up on these children. So this is, we basically have a person who is based at the facility who periodically updates this tool with the records of the children who are in care. So what are some of the lessons we've learned? We have also been able to identify the gaps in treatment and be able to close them appropriately. It has also increased on the proportion of children who have a viral load test result from 93% to 98% over a period of 1 year. And then also it has increased on the proportion of exposed children and siblings testing for HIV, and then also getting to know their viral load results. Next. So the third strategy is attachment of children living with HIV, as well as provision of treatment literacy. So why do we do this? We basically attach these children and adolescents to treatment supporters to be able to promote adherence. Like we say here, we ensure that this has helped us to ensure that the child is taking the right medicine at the right time, the right dosage, the right way, and the right frequency, which is so good, rather than just leave these children without being closely supervised when they're taking their drugs. Also, it has also helped us to be able to provide accurate information on the HIV care and treatment, as well as prevention. And how do we do this? We basically attach these children to their peers. And in Uganda, we have the YAP model. We call it YAP. That is young adolescents and peers. And then we have the caregiver directly observed therapy. So we attach these children to treatment supporters to be able to support them to promote adherence. And then we also provide the community health workers with the caregiver literacy handbooks to help them to be able to provide information that is tailored to support these other children with advanced HIV disease. And then we periodically also hold ART treatment literacy sessions. We hold this on a weekly basis to be able to review on how these children are coping with the treatment. So with this intervention, we've learned that there are more children who are monitored, children are retained in care, the children are attending to their appointments, and then children are actually attaining a suppressed viral load. Next. So strategy number 4 is we conduct joint home-based support. This is basically for enhanced service delivery to our adolescents. How do we do this? We normally make weekly contacts. So we have our community health workers who who actually on a weekly basis contact these children. For children who are having challenges, maybe distance challenges, going to the health facilities, we have also devised a mechanism of delivering drugs to the households. These are basically children in the institution. These are children of with advanced HIV disease in the institution, so we support them basically to have them reached with the drugs at the household. We also provide emergency transport. Sometimes we get these children onto our bikes, or sometimes we can send them some little cash to facilitate them be able to move to the health facilities. We also provide temporal food support for children with advanced HIV disease who have reached that state because they are having food deficiencies and so are unable to take their drugs as expected. We also refer them periodically for viral bleeding so that we are able to monitor them from an informed point of view. So this has basically helped us together with the health facilities to be able to identify the challenges affecting the children. And then we have also been able to support these children using the locally available resources, because once we make a home visit, we're able to see the various opportunities that might have not been seen by these beneficiaries, and we help them to address the adherence barriers. And then we have also strengthened, we have also realized that this has helped us to strengthen the community support system. For example, when we make a visit to the household, we find that this child could be having an unreliable caregiver, or there is no treatment supporter. So we are able to map in the community these children's relatives, or maybe any other person who is available in the community who can ably be able to support, to monitor this child, and then also be able to provide the necessary kind of supervise these children while they take their drugs. Next. We also conduct periodic case conferences at the sub-county level or division level, and then also at the health facility level. As you may see that this is a team that is now conducting case conference. So we basically conduct case conferences for purposes of supporting children with complex cases, or for example, children who have chronically been unsuppressed. So we conduct a case conference to be able to generate ideas from various stakeholders on how best we can be able to support these children. We conduct periodic multi-stakeholder meetings involving clinical and community social service actors, where we are able to discuss critical cases that may require joint action. And then basically now we also conduct joint action planning for effective case management. And so this has helped us to be able to identify the underlying factors or factors that are affecting non-suppression among these children, and be able to come up with key response strategies to supporting these children. Lastly, we also have the household economic strengthening approach, because some of these children, they are not suppressing because of the socio-economic well-being, socio-economic situations at the household level. So basically what we do, we support some of these children together with their caregivers. We link them to savings and credit entities. We also build their capacity in management of income-generating activities, and we provide them with the financial literacy. And with this, it has helped them to be able to improve household stability and be able to respond to care as expected. So with this, I want to thank you all for listening.
Thank you so much, Paul, for this very remarkable presentation on how these different social mechanisms that support and improve the quality of life of our children and adolescents who in one way or another presents with advanced HIV disease. I can see how the strength that is on the facility and the community, the linkage, and from where you started with the utilization of pediatric tool to do the gap analysis, conducting a root cause analysis as well, and improve even the social and economic benefits of these young people by even assessing the environment that these children are living. Thank you so much. I believe we'll have many questions to learn from you. Now we move to our third presenter, Miss Bukola Ayinde. Miss Bukola, she's the Community Advisory Board member of the AfriCweb. She does treatment advocates and educator with AfroCAP, providing essential HIV treatment, care, and support to people living with HIV in Nigeria. And she has a passion to facilitate access to optimize treatment and fostering community engagement to boost retention in care. So Miss Bukola will take us through on the community clinic support and prioritizing the children's rights and health needs. Welcome, Miss Bukola. Thank you.
Hello, good morning, good afternoon. My name is Bukola Ayinde. I'm from Nigeria. I'm a CAP member for AfroCAP, and I worked on community engagement for advanced HIV disease for AfroCAP, which I'm going to be sharing experience about today. I'm going to be talking about community and clinic support, AHD literacy. What are those missing rights of children and health needs? And I'm going to be sharing some of the outcomes of the community engagement that I was involved in. So I'm a member of AfroCAP, African Community Advisory Board member. AfroCAP is a regional network of HIV treatment advocates across Africa. And sometimes in 2019, an AHD CAP was established in Nigeria. Myself and two of my friends that you can see on this picture were the AHD CAP for Nigeria. And we implemented a community engagement program between 2019 and 2022. AHD was rolled out in Nigeria in 2019, and a community component was also established to provide community with information and education around AHD, and basically to improve, to support community to have a better understanding of AHD in order to improve uptake of AHD services and commodities in the facility. So what did we do? Initially we had a training for about 56 counselors from 28 facilities in Nigeria. We selected counselors from these facilities. And one of the criteria to participate is you have to be an adherence counselor and you have to be a person living with HIV. So we selected 2 per facilities and we had 56 in all. And the objective was basically to build their capacities around capacities on AHD, and for them to be able to provide same for patients so as to improve uptake of AHD services. So what did we do? We started with a training for this adherence counselor. We trained them on the various AHD packages that were available. We trained them on referral and then the support needed for AHD patients. So they in turn were expected to provide counseling, to provide information and education at the facilities to patients so that these patients will have a better understanding and they will be able to access these services. Another thing that we also did was that routinely, like twice in a year, We follow up with this adherence counselor at the facilities. We follow up, we mentored them, you know, go to the facilities, see what they are doing. They give us feedback. What are their challenges? What has been the uptake of AHD service? What has it been like, you know? So through that means we have a real-time feedback. We're able to feed this back to the government or to the management so that interventions could come in. You know, for example, they let us know when there are stockouts. They let us know when patients are not able to access their services, when the patients' time were being wasted. You know, there were lots of things that were coming out from this feedback. Another interesting thing we did was that we developed a lot of countless resources, a lot of high-C materials. In each of the facilities where we were working, there were roll-up banners talking about AHD, so that as you're coming to the facility, you're seeing the banner, you are asking questions, you know, and then through the information they were providing, people were made to know what the signs for AHD are, you know, where you can look out for AHD and what you should do when you notice that you might be having advanced HIV disease. We also formed a WhatsApp group with these counselors so that we are able to exchange ideas and talk, and then we're able to learn from each other, you know, because one counselor from one facility can learn what they are doing in other facilities. Those were part of the things we did. And when we did all this, some cogent things actually came out, you know, some things, some important gaps were identified that we feel were very important for the success of AHD and the outcome of AHD services in patients. And I'm going to quickly talk over some of them now, because if people don't have access to some of these things, it's going to disrupt their accessing AHD services. It's going to disrupt the outcome of their treatment as well. So during the community engagement program, after we had the community engagement program for 3 years, some issues came out outstanding that could actually be barriers to having a successful AHD treatment, you know, and I'm going to be talking about some of those issues now. These are issues about rights of patients, rights of adolescents, and rights of children. They are like gaps that we identified during the implementation of the community engagement. The first one was the issue of awareness, providing information to patients. You only assess a treatment if you are aware of it. If you're not aware of it, there's no way you assess it. So it's very important that there's an increase about awareness about AHD, information and education about AHD to patients at the facility, at the community, or wherever we can see them. And it's also important that we provide this information and this awareness in a language that they will understand, preferably in local languages, in any form that we know they will understand. When they have an awareness and information about this, they will be able to access the service. They need to know what are the symptoms, what are the signs of AHD, what should they look out for? And when they find it, where are the facilities? Where do they make the referral? Where do they go? And what does it entail? So that is very important. Another thing that came out glaringly is the issue of continuous access to AHD screening tools, drug and services needed. It's very important. A lot of patients will come to the facility and they'll be stuck out of AHD screening. They'll be stuck out of drugs. Patients will be asked to go and buy their drugs. Patients will be asked to come back for their screening. And in the process, they are lost to follow up. You know, so it's very important that while implementing AHD services, patients have continuous access to screening tools. Patients have continuous access to their drugs. Patients have continuous access to every other services that they will be accessing, so that they are not discouraged and they don't get lost to follow up in their treatment. Something that also came out glaringly, especially for children and adolescents, is the need to link them up with other services. When children and adolescents are being managed for AHD, other issues come up, like the issue of malnutrition in children, you know, and you find out that these children will get better, they go back home, and they still come back with AHD again. And that's because they suffer malnutrition, they lack good diet, you know. So it's very important that when AHD program are being implemented, there should be a linkage to other services, you know, like nutrition for children, so that these children who are malnourished can also be supported. And when this came out while we're implementing our project, we now realize that it's very important to identify organizations who do this. There are not many of them, but it's very important to identify one. They are going to contribute to the success of AHD treatment in children. It is also necessary to have feedback. While we were implementing the project, we had a WhatsApp group. And on a daily basis, the adherence counselors were giving us feedback on what is happening in their facilities. They give us feedback when there is stockouts. They give us feedback when patients are being unnecessarily delayed. They give us feedbacks when they're having patients lost to follow up. And when we get this feedback, we are able to feed back to the policymaker, you know, and by that way, they're able to take action and make corrections. So we don't have to wait till the end of 1 year. We don't have to wait till the end of the program before we get feedback. As we get feedback, we are able to make right inputs into the program for right corrections, right inputs, and that will improve the success of treatment and the success of AHD program implementation. We also found out that it's very important to follow up caregivers. A lot of the caregivers, especially for children, will go back to the community and then they will not come back to the clinic. And when the adherence counselors follow them up, they found out that some of them were being distracted by traditional healers who promised them healing through traditional medicine, and they didn't come back to the facilities. Some of them were engaged by spiritual leaders who promised them healing through spiritual means, and they were not coming back to the clinic. So because our counselors were able to follow up, they were able to persuade, provide them information, you know, and then make them come back to the clinic. In fact, in one of the states, we had the state management intervene by organizing a program for spiritual leaders to make them have a better understanding of the need for patients to come to the facilities to accept their treatment. Privacy and confidentiality, especially for adolescents, is also very key, because a lot of our young people, aside from their, when managing them for AHD, they might also be in need of other services like sexual and reproductive health. When they need these services, they should have confidence that their privacy and confidentiality is ensured, so that they'll be able to discuss with healthcare workers about these issues, because this will help their treatment. If we are managing them for AHD and they cannot discuss their sexual and reproductive needs with us, we might not be making success with our treatment. And lastly, the introduction of user fee in form of consultation fees or laboratory fees really affected access to AHD services. A lot of our caregivers could not afford some of these user fee or this consultation fee, and so they couldn't come to the clinic. Or when they come, they couldn't access services. So it's very important that we look for a way, is either to eradicate this user fee or support these patients to be able to access, you know, have a means to support them. We can build their capacity. You know, we can look for organizations to support them financially to help them so that they'll be able to access these services, or else we will not be making headway with our AHD treatments. And this last slide is just showing some of the work we did. Like the banner is some of the things we placed in the facility, which is talking about what you should do, what you look out for to identify AHD, what you should do when you have AHD. You know, every of this facility has this banner, and this really helped. Also on the screen, you will see a link to some of the IEC materials and some of the resources that we developed, you know, both for AHD and some other community engagement activities we had. All this can be obtained on this on the link on this slide. So I'll just say, in summary, access to information is very important. Linkages to other necessary services is key. Ensuring privacy and confidentiality, and as much as possible, disallow of user fee or consultation fees. They will be good enablers that will help patients to assess their treatments and services of AHD. Thank you very much.
Thank you so much, Ms. Bukola Ayinde from Nigeria, which shares the activities that they're advocating to make sure that the right of our children is well understood in the community as well as in the facility. And the key issue here is making sure the information is everywhere and making sure the caregiver understands the rights of children and adolescents with advanced HIV disease to receive evidence-based care which are available. So thank you so much. And now we are moving to the question and answers and our discussion. So you can either raise the hand or write on the Q&A board so that we can respond. To start with, there are 3 questions in Q&A and 1 question from the chat. And also I have additional question for Dr. Swilanji Sivile as well. First one goes to Uweso, Uganda. This is from Harare. They asking, which income generating activities are you implementing, and have this had documented impact in improving the health status of children with advanced HIV disease? Over to you, Paul or Mr. Saad.
Okay, so let me start, and if my colleague has something to add on, he can be able to add on. So basically, the kind of key projects that we support our children with advanced HIV disease, they include liquid soap making. And then we also have bakery. We support them to be able to start bakery projects, and then also crafts. And some of these crafts, they include like making of handbags, making of bead bags. And so this has greatly impacted positively onto the lives of our adolescents, that some of them have moved as far as even being able to now from small scale, some of them have now advanced to the level of even being able to brand some of their products and be able to market them at the supermarkets that are available. And so this has greatly helped them to be able to improve, to be able to generate some incomes to support them, be able to meet some of the basic needs like healthcare, clothing, food, and many others, and be able also to even support some of their siblings to be able to get to school. So this has greatly impacted our adolescents, and this is documented. Sad, if you have any other additional information.
Thank you, Paul. Adding to that, there's also additional question that were asked is what qualifies a child for emergency transport, and what measures are there to promote sustainability after the 5 years of program? They said from their experience, are there any, from your experience, are there any challenges you have encountered in delivering medication to a household? For example, accidental disclosure.
Okay, thank you so very much. So in terms of qualifying for emergency transport, at the time of enrolling some of these children, we basically do an assessment, and we were able to categorize those who are in the institution. Those who are having challenges to be able to generate some kind of incomes, or maybe having challenges going to the facility. Then we also have record of our children, most especially those who come from very far away from the health facility. Sometimes some of them their facilities are as far as about 10 to 20 kilometers away. And so they are not able to get to the health facility to pick some of their drugs. And so we basically use some of those yardsticks to be able to support them with emergency transport. Now, sustainability of this, that's why we are calling it emergency transport, because we don't provide this forever. We map such cases of children, and then we actually support their caregivers to be able to start income-generating activities. And some of the income-generating activities, I have already talked about them. So we start by helping them to come up with some of those activities, with some of those projects, and then we also help them to join the village savings and loans associations. So we have a group, we mobilize groups of beneficiaries at the community level to be able to form a village savings and loans association. And then thereafter, we grow them up to register them with financial institutions, and then we empower them to be able to acquire some of the loans and be able to boost some of their income-generating activities. And with this, it has helped them to be able to now be able to meet the transport costs on their own. Then in terms of some of the challenges, yes, it's true that some of these challenges exist, that there can be issues of accidental disclosure. But we have tried as much as possible to conduct this activity jointly together with the health facility teams who are very much trained in these aspects. And we, as much as possible, try our best to make sure that there is a confidentiality at all levels. Thank you.
Thank you so much, Mr. Paul. So there will be another question for you, but let's move to Ms. Bukola. We have a question for you. Is there a possibility to involve the traditional healer in the management of advanced HIV disease, especially at the level of referrals, since most of our parents believe in them if they can help us refer them back to the health facility? Thanks.
Yeah, thank you very much for the question. Yes, they have a great role to play, both the traditional healers and spiritual leaders. Like I was saying, when this happened in one of the states where we worked in, we were able to get the support of the government at the state level, and they actually put together the traditional leaders to provide education for them, because the people really believed in them and they have a lot of faith in them. So they did that at that state level, and that helped. So it would really be nice to have this as part of policy, that these traditional healers and spiritual leaders are carried along from the onset when we roll out programs like AHD and some other programs, so that they can also provide support at the community level and refer people back to the facility. Thank you.
Thank you. So I can hear that in the next move is to make sure that these spiritual leaders and traditional healers be educated on managing this advanced HIV disease, or recognizing the individual with advanced HIV disease and refer them back to the health facility. Thank you so much. Another question goes to Dr. Suvile. They said, can we say that for AHD activities is necessary in achieving the fourth 95?
Yes. And you said the third 95, which is biosuppression. You need people to be well for them to be suppressed. There is some data actually that shows that, for instance, people who have TB, the viral suppression kind of goes up. There is such interactions. Yeah. So besides that, it's very difficult for somebody to be adherent to treatment once they have these opportunistic infections. It's not really managed well. Yeah. So, but I think the main thought should be that it's
you cannot claim to have epidemic control if at the end mortality is not controlled, because that's probably an impact outcome for everything that we do to try and control the HIV situation. Especially that if you go by population proportions, you know that children are very few. You have maybe 4% of children who are living with HIV, but they contribute to something like 25 to 30% of the deaths. So deaths are disproportionately high in the children, and all children should be considered to have advanced HIV disease.
Yes, thank you so much, Dr. Sibile. Another thing is, what is your take with this campaign on Global Alliance to End AIDS in Children by 2030? Do you think they've covered enough, especially in making sure these children and adolescents with advanced HIV disease being covered and reduce the number of community deaths?
Yeah, I'm a big proponent of the alliance. I think it gives us a platform to bring up even more issues which were not probably initial thought. The initial thought was to deal with mainly with prevention and so not to have the cases, but we need to think about management. I think to the global players, and I've seen on the call we have a lot of colleagues who are in the lobbying space. I think our work should be to ask that somehow we can have that alliance funded. Most of our countries have developed very good plans for the alliance documents, which are very, sound, more launched and presented at call it the Dar es Salaam Declaration. So we need to work on the funding piece, that these documents, what we intend to do there, we should be actualized. And once that is done, we can think of how to extend the thought to make sure that advanced HIV disease issues are actually covered adequately as well.
Thank you so much. So I can hear that the activities are there, so the fund is an issue, but we can start with those activities and improve this and reduce the number of community deaths in our communities. Back again to Paul and Mr. Saad. How are you dealing with the challenges of late disclosure to improve the health outcome of children with advanced HIV disease?
Okay, thank you to everyone and the person who asked the question. We basically have two ways that we deal with this. And the first one is we periodically conduct training of our community health workforce, most especially in the areas of disclosure. And so that's one approach that we've employed, so that they are able to, we equip them with skills on how to be able to support disclosure. And then two, we collaborate with the health facilities to be able to generate baseline information regarding all these children under our care. And so once we collaboratively generate this information about these children, we are able to quickly flag them. We flag those who have not been disclosed to and follow up for supported disclosure. So basically, that's what we normally do.
Okay, thank you so much. I think there are so many questions and we are running out of time. But Ms. Bukola, they really wish to get that link for Clinton Health Box. On the, I think we'll provide in the Linking and Learning Hub. And then there will be some question that you can also respond. All of you can respond to the question that you feel that is appropriate to you to answer on the question and answer chat board. With saying that, if there's anything that we can round up, just one sentence from you, a take-home message. From each of you.
Okay, so let me just say that a lot of things we have spoken about today and a lot of things we have seen around really shows that community have a lot of roles to play in the success of AHD implementation in children and in adolescents. So let's get to do more innovative, come up with more innovative strategies from the community to support AHD. Thank you.
Thank you so much. We are running out of time. Dr. Suvile?
Yeah, I think for me, it's just to say that we are able to control the HIV epidemic in children and also control advanced HIV disease in children specifically. And so we need to work harder. The tools are there. We know what to do, but we need to probably put in more work.
Thank you. And back to you, to Paul, Mr. Paul.
Oh, yeah. Thank you so very much. I think for us from the community perspective, we actually have a great feeling that if we strengthen the community support systems, then we shall be able to greatly support these children with advanced HIV disease. Because, you know, at the facility level, they are giving the drugs and the rest of the things, but it's at the community where a lot takes place. And so if we strengthen the community support, social support systems, then we shall be able to support these children greatly. Thanks.
Thank you so much. Thank you all for attending this cafe, and any burning questions, you can still post it and they will be able to answer through the Linking and Learning Hub. Thank you so much. We are ending our session. Thank you, presenter, for this very informative session, and we wish you all the best in the afternoon. Thank you. Hope you join us to the Pater Reel. Thank you.
Oh, thanks.
Okay.
Bye.
Bye.
Thanks. Bye.